going to say.
Thank you, Caitlin. Good spot. All right, my name is Kyle Zagrodzky. I'm the founder of OsteoStrong. I want to thank you all for coming today. How many people here are currently members of OsteoStrong? Okay, a good group. How many are never heard of it or is it their first time here? I can see a show of hands, a smaller number. Good. One of the reasons why we have little lectures and talks like this is that OsteoStrong, and I can say this confidently, I believe, is one of the most profound systems for human physical development. And this is the next generation of what we're going to see around fitness for all levels. The reason why it's so profound because it simply triggers what your body is already designed to do, grow healthy tissue. You can grow healthy tissue in bone and muscle, improving bone density and balance like nothing before has ever been created. The testimonials we see are amazing, but even more important than testimonials are the actual research. And so the Dr. Jaquish, who is the man behind our equipment, who really was the inspiration for me starting this brand, is a good friend of mine. I want to introduce you. He's going to talk to you about why this system is capable of doing what it does. Dr. John Jaquish.
You got me? All right. Hi, good afternoon. I didn't do a sound check, so am I okay? Everyone can hear me? Okay, perfect. I'm going to be presenting, and then we're really lucky today. Basil Hunt is here, and he was one of the researchers that did some of the independent research that was done at a London hospital. So when physicians look at different bodies of research, like I'm the inventor, I did my own research study and it was published, but it's much better when someone else can replicate what's been done somewhere else, so you know you're taking all other variables out of that. So we're going to talk about osteoporosis and musculoskeletal dysfunction. You're going to hear a little bit about the association between osteoporosis and type 2 diabetes. That's not always in the same conversation, but that is the modern way of thinking about those two dysfunctions, because they're both metabolic dysfunctions of particular cell sets in particular systems. Osteogenic loading therapy and how it started. We're going to talk about the physiological principles. This is the same lecture that I give to physicians, but I'm going to go a little faster through some of the science. And if you have questions, save them to the end. And I'll focus more on the application type things that we all take advantage of here every week we come in. I'm going to talk about osteogenic loading in muscle, what this means to OsteoStrong, and then physician referrals, what to say to your physician, or if you have friends who have heard about what you're doing here and they're very excited about it, what to say to your friends so they can explain to their physician what's going on here and how to share that excitement. Okay. Okay, so osteoporosis. Does everyone realize that there's a growth in diagnosis of osteoporosis? Show of hands. Okay, so there's a few reasons for this. Most of them are lifestyle, meaning both dietary activity. We don't receive the types of impact that people used to receive. We also, just kind of an anecdote, we walk around on paved surfaces, so our feet don't do the same job. And the complexity of the human hand is very similar to the complexity of the human foot. But when you walk around on pavement all day long, your feet aren't able to really develop, and that dysfunction echoes through the entire body. So that's why we're seeing these areas of dysfunction. So, sorry, this slide was actually supposed to go ahead of that first one. I always talk about the limitations in disclosure. So I'm a consultant of the company, OsteoStrong. Basil has no conflicts of interest in it. I want to point out, it's really important for me when I present these things, and these are the kind of things that you'll repeat to your physicians and friends. The data that we have is consistent with the type of physical medicine interventions, physical therapy type things that are tested and published in peer-reviewed academic literature. But it's not at the same level of like a pharmaceutical. So, and the reason is when you create a drug, chemical that's not found in nature, and you want to test it with humans, there is some very significant rigor, and of course there are questions that even if that is enough in some certain cases. You have an opinion on the subject. I can see you shaking your head. So instead of that, what we're doing, and Kyle touched on this is a type of therapy that triggers the body to fix itself. So what we're really talking about are the principles of human physiology. We're not necessarily talking about a particular machine. There happens to be the particular system back there that does this, but the growth, the adaptation is really the human body. We just now, for the first time, have a venue to trigger the human body to do all that it can do to be as powerful, strong, and resilient as it can be. Okay, hip fractures are the most studied fractures. The reason is because they end the most lives. So hip fractures actually have a very similar mortality rate to breast cancer. Now the reason is someone falls down, they break their hip, or they break their hip as they fall, which is very common too. And these hip fractures keep people from being able to move, so then they start to have cardiovascular dysfunctions, breathing problems, and then they can, pneumonia complications end up ending their life, and that doesn't need to happen if they don't have the fracture to begin with. This all started because my mother was diagnosed with osteoporosis. So I was in college, and she said to me, I came home one day, and she was really upset, and I think I came home to get my laundry done and maybe get something to eat. Yeah, you can see that. So, but when I saw my mother, how upset she was, I asked what's going on, and she said, I'm going to die. And my mother's dramatic, so I had heard that before. But when she said she'd been diagnosed with osteoporosis, I said, well, let me look into that. And as I started reading about osteoporosis, I thought, oh, okay, this is a real thing. She's not overreacting. And so as I was reading about it, more than 10 years went by where she was worried about this. And it's a loss of the activities that you love. There were times where I would want to go rock climbing or bike riding or something, and I want my mom to come, but she didn't want to. She was in her 60s, and she goes, no, I'll fall, I'll break something. So she wasn't able to do the things that she loved to do, and that's very painful for somebody. And so as I started reading about this, I came to a conclusion that this was a very solvable problem, because this is important. All the other stuff you can forget, but this part, remember this. Osteoporosis is a disease of deconditioning, and anything that becomes deconditioned can become reconditioned. So when you don't put the proper, whatever it is, nutrients or stimulus on a certain part of the body, be it your eyesight, ask lawyers about how their eyesight degrades very quickly in comparison to people who actually get to look at things not right up close to their face. There's a loss of that. Are you an attorney? Is that why you're laughing? Okay. So when we live in an environment where we can't put these types of loads on the body to trigger growth, and what I ended up doing was I looked at research in gymnastics. Gymnasts have the highest level of bone density of anyone out there. Far higher than any sport, and it's because of the way in which they hit the ground, the momentum behind their hitting the ground, the multiples of body weight they absorb through the musculoskeletal systems are incredible. And they also injure very frequently. This is not a safe sport. Nobody gets into it because it's like a safe thing to do. They get into it because they just want to do it. So of course the joke, I said to my mother, you just need to become a gymnast. But as I started reading more about it, okay, what if, in the research task, how do I make an environment that is safe for all ages to get to that level of health? That was the invention task ahead of me. So as everyone has looked around the corner, I did that. So I tested it with my mother. She was very unhappy the whole time. It wasn't pretty and painted. The first one was made out of wood and chains, And I took duct tape and put some towels, you know, for like pads. She was so upset. But after 6 months, she was thrilled because she went and got another DEXA scan. And so she had been declining for a long period of time, more than 10 years. And then all of a sudden, she's gaining bone density. So then she started to believe me. So for the first 6 months, apparently, she was just angry. So now I tested it with 400 other people in a facility very similar to this in Napa, California, and it worked. I published a book. I've since published a number of clinical studies, and now it's able to help tens of thousands, even millions of people around the world. So it's very important. This is how it works. So there are the principles here. It's called mechanotransduction. You don't really need to remember that. Even spell check doesn't like that word, so, and that's the right spelling. So axial bone loading now has a dose response. So mechanotransduction really means you put load on something and something happens, like inside the body. So we put load on the body, and before, if you read any of the information about bone health treatment, I'm on the board of directors of American Bone Health. The recommendation traditionally has been resistance exercise. Well, resistance, I can pick up this bottle of water, that's resistance. Is it doing anything for me? No. So after I did some of my initial data collection and publishing, some other researchers who I would see every year at the World Congress on Osteoporosis did a study to try and determine what the minimum dose response was. It's really important in medicine because whenever somebody creates a new thing, a drug, radiation, whatever, they try and find out how little of it they can give to you to get the intended effect. So the question after I was publishing things that were similar to this that showed 8 multiples of body weight, they think, wow, that's incredible that this postmenopausal individual is able to put that level of force through the hip joint. That's what we're loading right there. What is the minimum? And so what they did is they took accelerometers and they taped them to people's hip, and then they had them go through impact-like exercise, and then you can draw somebody's blood right after they go through an impact and tell through, it's called a marker, a blood marker, if they are triggering bone growth or not. And it turned out that in a wide array of ages, all the way from teenagers to elderly people, they found out 4.2 multiples of body weight. That's the minimum. So when someone says, oh, I do plenty for my osteoporosis, I do yoga. Do you think you're getting 4.2 multiples of your body weight in yoga? There's no way. Exercise, running, not even close. So, the answer is when children absorb high impact force, when they're standing on a furniture and jumping off, or when you hear a little kid running down the hallway, they pound their heels, right? They sound like elephants. They're little 50-pound kids, and they're making so much noise. And the reason is they're driving their heels into the ground, and that's what triggers bone growth. They don't know they're doing it, but they're doing it. So now what we also see is this is a solution that is all-encompassing. So a pharmaceutical that affects drugs, a pharmaceutical that affects bone, it affects just the bone, right? Not the entire musculoskeletal system, except all these things work together. So, for example, 450 joules, which is, if you convert that to pounds, it's like 600 pounds, will shatter an average femur. Well, I stand on one leg and jump and land. I just absorb a load like that. How come my leg didn't shatter? Well, the reason is because the entire kinetic chain, the muscles, the tendons, the ligaments, all work together to absorb that shock so those peak loads don't get high enough to cause a fracture. So the whole system works together. There's a great study they did with foxhounds where they, that's a type of dog, where they dropped these dogs and they would be able to absorb incredible impacts, and then they'd wear them out so they could barely stand, and then every time they drop them, they'd break. Don't worry, they ethically treated the dogs. It's very savage, very cute dog. So they showed that it is the deceleration that you're going through. And here what we're doing is we're improving the performance of all tissues involved, the entire musculoskeletal system, the tendons, the ligaments, the muscular tissue, and of course the bone itself as an all-encompassing fracture prevention solution. So some of the clinical data, this Basil and I, this study was what we worked on together. There were 55 subjects, and they increased 14% in the hip and 15% in the spine over 6 months. So this is 5 times more powerful than even the most impressive clinical trial of a drug that's ever been seen. And of course, no side effect, just a great effect, and confidence and activities that those people could do at the end of these studies. So this was also a follow-up to a larger study. So when your physician asks you, well, 55 people is a small sample size, which, like I said, is common in physical therapy. There was another study with 2,300 subjects, which looked at the pre and post differences in the ability to put load through different joints. So this is where different standards of care stack up against what we're doing here. So there were 2 studies done with osteogenic loading, and these are the other things. So, bone anabolics, bisphosphonate drugs, weight-bearing exercise, usually fairly high intensity to show any positive result at all. So this is there's actually 152 studies compiled to put all this data together. So no activity, non-active lifestyle, no activity with calcium and vitamin D, you're just losing a little bit less, but you're still losing. So below this line, you're losing bone density every year. And so it's only here, and these 2 things are drugs where you're really gaining it all. And like I said, with a 4.2 multiples of body weight, that's a lot, and it's not easy to get, and therefore there's really not a whole lot to do to build bone other than putting these very high levels of force in these very safe positions. One thing to think about, and this is something you can explain to your friends also, is the positions that we use here are the same positions that you would use to absorb high impact force. So if you trip and fall, you put your hand in front of you like this, and that's how you absorb that force. You wouldn't put your hand close to your face, because there would be no biomechanical advantage to that. It's your own reflexes. Know that if you jump and land, you're going to have a 120-degree angle behind your knee every time. That's your own reflexes, know to choose those positions. So we're leveraging those positions to trigger this effect, because in those positions, we are capable of producing and absorbing incredible forces. There's a new education resource for somebody who doubts what 4.2 multiples of body weight is, or they say they're sure they get that at the gym. There is a application on the App Store that you can download called Fracture Proof. And you download it, you put it on your phone, you hold your phone against your hip. Anyone who's confused doing this, you can have your kids do it for you. You can see a couple looks like. You hold your phone against your hip and you jump in the air and land. And it will tell you your body weight, it'll tell you how many multiples of body weight you absorb, because there's an accelerometer in your phone. Very simple application, and it'll tell you just how challenging it is. And it also might be fun at a cocktail party to pass your phone around and show your friends who tell you that they know a lot about this, that they're sure their exercise program is enabling them to grow bone density. You can just show them that it's a little more challenging than they may think. This application, it benefits American Bone Health. So that's the partner group in this. American Bone Health is also a partner with OsteoStrong, and they're the largest patient-based osteoporosis education institution in the world, but they're here in the United States. So they have little education events just like this. In fact, I do some of those. Okay, type 2 diabetes, I'll go over this fairly quickly. This is the most important statistic. 1 in 5 healthcare dollars is spent on metabolic disease. Metabolic disease is both pre-type 2 and type 2 diabetes. So that's an incredible cost. It's the largest cost in our healthcare system. If you were to cut anything out of it that was like the incredible thing, this would be it. Now, those of you that don't know how to read like fasting glucose levels, basically the higher the number is, the worse you are. From hemoglobin A1C standpoint, like 5 and 6 is good, 7 is not really that good, 8, 9, 10, terrible. So there was another study that looked at individuals who were told not to lose weight because we wanted to just isolate what happened to muscle when people went through this osteogenic loading therapy. And they were told not to change any other variables. Don't change your diet. Don't start taking supplements. We wanted to make sure we really isolated just the effect of osteogenic loading therapy. And these were the results. So these are monotherapy. Usually in diabetes studies, they'll have somebody try and lose weight and try and exercise and metformin. That's the standard for diabetes treatment. Yeah, actually metformin's a great pharmaceutical. There's hardly a side effect at all, even in higher doses. And so what these studies do is they stack all these things together, which would be a normal protocol. But for our purposes, we just wanted to find out what our solution did by itself. So somebody with type 2, they may do osteogenic loading and take metformin and, of course, go on a calorically restricted diet. And there are individuals who come to this facility who have had tremendous results by doing even just the calorie restriction and the osteogenic loading, or cutting some of the simple sugars out of the diet, things like that. But as a monotherapy, this performs the best of all of the things that are out there. Okay, so I explained blood glucose absorption and how you want the lower levels. There was first a research study done at the University of Wyoming, and that's what triggered this study. This was another one that was done in London, and Basil was a principal investigator on that as well. So here's what's going on inside of your muscle cells. Now, these are single cells. So when you explain this, make sure not to say you increase your amount of muscle cells. That's not a thing. What you do is increase the density of the cell. So this is what happens when somebody is going through regular exercise. They basically hold more fuel in the cell for contraction. So when you go to the gym or pick up a regular weight, it's called sarcoplasmic hypertrophy. You don't need to remember that. What we're doing here is called myofibril hypertrophy. You don't need to remember that either. But I'll probably buy you a drink if you do remember it. There's two different types of adaptations, and this one's really important because each one of these new myofibrils comes with a fresh set of receptor sites. So what happens is what's called GLUT4 signaling goes up, and more insulin and glucose can get into the cell and be used for better metabolic management. And so that's what's reflected with the darker and lighter colored myofibrils here. So strongest evidence to date that this, especially from a non-pharmaceutical way, treating diabetes, but also just from a strength and performance perspective, we're increasing the density of the cell. So what I hear from women frequently is, I'm afraid to be involved in certain types of exercise programs because I don't want to look, they're looking at me, they go, I don't want to look like you. And I say, yeah, don't worry, you won't look like me. Don't shave your head, that'll help. But you need to make sure that you're doing the type of training stimulus in the body, not called training, therapy, to really trigger what you're looking for. And this is everything you do. It's got to be aimed at your goal. So with osteogenic loading, we are stimulating the density of the cell. This means the muscle becomes more powerful, but it doesn't get any larger. So the females in the audience that may be a little afraid, like, oh, I don't want to look like a lumpy person, you won't look like a lumpy person because you'll become more powerful. Every muscle will feel harder, but it's not necessarily anything's going to get larger. Now, for men, muscles do get a little bit larger. Nobody really has a problem with that. I don't think. So there's conventional therapy. It just doesn't have the same results as what you see here. You can see the kyphosis. In fact, you guys can probably have trouble seeing that over here. But it's somebody who's very kyphotic, and just a number of therapy sessions later, this individual has changed their posture. So that's another thing that happens because this is a musculoskeletal solution. It's the bones, the tendons, the ligaments, and the muscle. These all work together, and all of those things are required to have good posture. So it's like someone's not going to take a medication for bone density and change their posture. That doesn't make any sense because the muscles need to pull the bones in the right place. The tendons and ligaments that hold everything together need to be powerful enough to not be in the deconditioned position, but to be in the conditioned position, which is what you see in this woman here. So, physician referrals. This is the kind of thing that you want to talk to your friends about. It's not for everyone. Nothing in physical medicine or pharmaceutical medicine is for everyone. That's not a thing. So if somebody is in acute joint pain, you just had an injury, they shouldn't be doing this. If they are on unmedicated hypertensive, meaning they have high blood pressure and they're not controlling it at all, that's the type of individual that needs to address that before they get involved in any type of high intensity activity. And muscular dystrophy. Muscular dystrophy just has a lot of complications when it comes to protein synthesis in muscle. It actually accelerates that disease. So, and some patients will need regular checkups with their physician. So when getting involved in the program or asking your physician, you can mention to them, well, I can come in here more regularly so you can monitor my progress. That does two things. That if they have any unfamiliarity with this, it enables them to watch what's going on, which keeps you, in their mind, in better care because they're watching what you're doing. But it also helps them understand what's going on. So they see week by week improvement. You know, even in deconditioned individuals, even in individuals that are elderly, there's improvement week by week, typically every week. So it's a great relationship to build with your physician as they can watch your progress, and they're learning too, because this is not yet the standard of care. This is still very cutting edge. So I'm going to have Basil come and talk about some of the psychological aspects of this. Basil's a clinical psychologist at a London Village Surgery, and he's also a fantastic guy. I didn't cut his hair. He did this himself. We happen to be very excited about each other's haircuts, but we met at a conference, and we were very excited about sharing what this therapy can do. But I'm going to let him talk about the psychological aspects.
Okay, good afternoon, everybody. This is my first time in the USA. Okay, so I'm a psychologist, not a scientist. And I think when we were talking about this study, we had a bit of a battle because I wanted to see the psychological results. He wanted to keep it very scientific. And I understood that because to get published in journals, you need to be scientific. But there's always an underlying story there of psychology for me. I'm very passionate about what I do, and it's all about empowerment. All right, so can you all see the screen from over there? Okay. Difficult, yeah? All right, so one of the things that I wanted to look at, yeah. All right, so if I stand over this side, okay, in front of John. So I'm just gonna steal the limelight for one slide. Okay, one slide. So I wanted to look at the psychological changes because I think that in any modality we can do the physiological, but what's important for us as individuals is our personal psychology. That is the real underlying driver that creates the change from within. And so what I did was to administer this Warwick Edinburgh Mental Health and Wellbeing Scale, and it's a scale that's used across the NHS in England. So it's a scale that's known by a lot of the GPs. So when they see the results in the name, they tune to the scale quite quickly. It's only 14 statements that is administered. I normally do that at the first session. And then I would repeat that at 12 sessions and 24 sessions. Because my study was just over a 6-month period. Now, what was important, and you don't see any of these results, in the actual publication, okay? But I do have the results. Now, what's interesting with the results is that those patients who actually showed a greater increase in bone density over that 6-month period actually showed a greater increase in their psychological well-being. Now, you might ask yourself why that is. Now, I am the kind of person, when I see you for the first session, I'm very passionate about what I do. Okay? And so, in terms of compliance, passion, how do I get that across to you? Because when you come to my sessions, you're coming to meet someone who's very passionate, but you're also bringing passion with you. Yeah? Because the passion is something that comes from within. Yeah? Now, some of my patients won't get to that stage until about maybe 5 or 6 sessions. It really depends where you are. Okay? Empowerment is also very important. What do I mean by empowerment? Because empowerment is something that you have to realize as members. You've got to be empowered to create change for you. So it's my job to empower you to find that change from within. Because I have a saying that everything begins with self. A lot of us tend to look for answers outside. Okay, we go to the doctors, the physiotherapists, we look for medication, we're looking for a quick fix. All right? Now, what I try and get across to my patients is this. The only one that's going to fix you is yourself. We all know, and I think, speaking to some of the members that I've met over the last week, you appear to be really educated in terms of medication and what it does, toxicity levels. And I've noted that. Far more educated than the patients I work with. So I'm constantly trying to educate my patients to understand the medication and the side effects. All right, so whatever you're doing is great. But the idea is that you really have to work and empower yourself, and to realize that the only one that's really going to fix yourself is you. Yeah? No doctor, no psychologist, no physiotherapist is going to do it for you. We will support you in getting there, but you will get there. All right? And the other thing is, what I try and work with that help to create change is being present. Now that might be a little bit foreign to some of us, yeah? Right? But being present is so important. Okay? And what I mean by being present is simply this. You have to know yourself. Okay? Because sometimes, right now, I'm being present in this moment with all of you. Yeah? Some of you might be sitting there thinking, okay, when is he going to stop? Some of you might be thinking, okay, my old tummy's rumbling, I could do with a cup of tea. And some of you might be thinking, this chair feels a little hard. Yeah? Okay? All right? So your mind is all over the place. Okay? Now, when we're truly present, and I teach this to all my patients.
Sorry, that's me. Probably was bigger.
What's going on there?
Sorry. Don't hide behind it.
Oh, okay. All right, so I teach this with all my patients because when we're truly present with self, you know, there's less stress, there's less pain, because stress and anxiety cannot coexist when you're present with self. But it's a learning that I work with my patients.
Talk a little bit about.
Now, the research study, okay, as I said earlier, I think John was trying to get me to talk a little bit more about the results.
That's what I was going to do.
Yeah. So I was just giving you this little background because all of that, yeah, helped to affect the results. Okay. So it's this work on a session-to-session basis that led to those positive results. Okay, you with me? Mm-hmm. All right? Mm-hmm. And so the scale, it rates from sort of 14 points, and when you're at 14, you are really, really low in terms of stress, anxiety, depression. Okay, you know, severe pain as well. When I did the initial results, we looked at all the patients, and they kind of average about 45 to 50 on the scale. And so the pre and post test results moved from 45 to 50 to 58. Now, you know, an 8-point change on a psychological scale is really great, because psychological scales sometimes only move 1 or 2 points. So to see a movement of 8 points over time really showed us that as a result of what we're doing on this program, that psychological benefits really have an impact.
One thing you said to me,
right?
One thing you said to me was the individuals who felt like their health was out of control, thereby it was a very frustrating subject for them. They got control. Do you remember saying? I mean, we talked about that over and over again during while we were putting the study together. Yeah, they had an ability to control the metric of their health. They saw something that they could grab a hold of and change it. And when they could change it, they felt they could keep going.
Yeah,
like
absolutely.
change.
And that's why I noted the power of control there. Okay? Because the power of control, you know, is something that you develop over time. Yeah? Okay? And what I mean by that is actually, you know, thinking about, and I think a lot of the members that I've spoken to so far this week have started to take back the power of control. You've decided that you don't need medication anymore, that you need to do something about it. So that's, you know, those are steps that you start to take back, power of control. One of the things that's important for this particular study that really led to, you know, reaching those kind of results is the preferred future. Is a question, you know, within the analysis that I ask my patients. What is your preferred future? That first session. So you're looking at what would life be like, you know, maybe in 6 months' time, a year's time. What would you expect to feel and look like? It's a powerful question. All right? So when I get them to look ahead and to determine and ask themselves that question, what would I feel like? What would I look like? And people around me in my circle, friends, relatives, what would they see? Yeah? What would they see? It's a powerful question. And when you get to explore those kind of questions, it really sets you on a positive path. Yeah? So, the psychological benefits from this study, I mean, it was a small number, so I'm looking at, doing another study over a long period of time using the same scale to see whether or not the results will get the same results or even better results. But, the psychological effects, on any program, I think, is very important. It's one of the key things that we have to grasp ourselves. Yeah? See that?
Mm-hmm.
Okay? Alright, so I'm going to hand you back over to
Oh,
John.
no, don't run away. Don't run away. We're going to answer questions, and some of the questions will be your questions. I hope the hard ones.
Go
Here
ahead.
for it.
Okay, the question I have is, was your study done completely separate from any knowledge of the results from anything over time of doing the program itself? In other words, was your study totally separate from any awareness on the part of any individual of how they were doing and what gains they were making within the program of doing it?
Let me get that one. Yeah, so it was pretty well known what happened in the first study, and it seemed a little unheard of now. So the first study, reason in the chart where you see the 2013 and 2015 study, there's a large difference in results. What I believe happened was the first group was quite a bit older, but they were very timid when they were putting the average 9 multiples of body weight through their hip joint. And of course, I remember there's one particular woman of the 12 test subjects who would see more than 1,000 pounds show up on that computer screen, and she thought, I can't believe I'm doing this. I'm really afraid, though I feel fantastic. I feel better all the time. And she increased her spinal density by 3%. So it was a huge success for her. The second group knew about the results of the first one. So they knew that it was done before, that individuals had absorbed many multiples of body weight. So that second study was much more like what's going on here. You know that there are thousands of people around the world who have put many multiples, 6, 7, 8, even 10 multiples of their body weight through their hip joint, 3 multiples of body weight through their spine, and the reason we stay safe as we do these is what's called neural inhibition. So your own comfort is what protects you. You can't squeeze a fist hard enough to break your own finger, right? So you also can't do an osteogenic loading session, place load on the musculoskeletal system, and create an injury because you got biofeedback on the computer screen in front of you, and you also have your own comfort, which if you become uncomfortable, will actually start to turn the muscles off, and you won't be able to continue and aggravate any particular problem. So the knowledge of what happened in the first study was passed on to the second group, and they proceeded into that study with much greater confidence. Great question. Yes?
Does this help people with back problems?
Back problems is a very broad subject. There's many different dysfunctions of the spine. However, in general, most people with a tendinous ligamentous muscular dysfunction in the back, a slip disc, something's not quite right, by increasing the strength of the tendons and ligaments, by increasing the performance of the muscles that surround the vertebrae, completely aside from increasing the density of the vertebrae, which also happens, that enables an individual to potentially build a buffer around any of the problems. I have 2 bulging discs, and on the spinal movement, I pull 1,500 pounds. So, and the first time I did it, it was actually 200 pounds. So I was a person with a very bad back, and now I've put a lot of force through the spine. And I have spine erectors that protect my spine. I have tendons and ligaments that are very powerful, and I feel no pain whatsoever. Yes.
Do you have any measures that could measure if the cartilage is being increased, possibly?
Interesting question. If Basil and I had only had that kind of measurement equipment, so there's new MRI, and I mean by new, like people don't have access to it, this is just researchers, that shows that osteogenic loading forces improve the, and this is important, quality of cartilage. Like if you damage your cartilage, if it's gone, it's gone. But what's there, you can have diminished cartilage and you can improve the density of cells even in damaged cartilage. Yeah, yes.
Can I, the question about back problems, you know, I work with many patients with severe back problems, and I've seen some remarkable results in the UK. Yeah. So it works.
Yeah, good.
How did you come up with once a week?
The metabolic rate. So the question was, how did we come up with once a week? Why is it once a week? The metabolic rate of bone and the metabolic rate of the type of muscle adaptation we're stimulating, myofibril. Remember that? I'll buy a drink. Do you remember that? The metabolic rate of those tissue adaptations is much longer than other like an exercise or something like that. So your bone doesn't adapt very quickly. Think about how long it takes to lose bone density. You reach peak bone mass at 30, and it takes a significant amount of time, 20, 30 years before it's ever really a problem, typically. So you don't gain it necessarily all that fast. You don't lose it necessarily all that fast. It's not the kind of thing like muscle where you can really have drastic changes in a short period of time. So the best thing to do is, you can actually affect it rather quickly here, but you have to let the stimulus happen, and then the body has to have time to respond. So once a week is actually the most rapid. In fact, Jolene mentioned, I don't know whoever knows Jolene, she's holding the pink phone right there. So Jolene mentioned, I've noticed some people that they like go on vacation for a week and they come back and they let 2 weeks go between, and they have an even bigger jump in progress. Has anybody see, you've seen that? Yeah. Anybody seen that? Raise your hand. You take 2 weeks off and a huge jump in progress. Because actually you're benefiting from even more time where the tissue is reinforcing itself and becoming more powerful. Yes, you have a question.
So follow up on the first question, in your study, did the participants know that their osteoporosis or whatever it was changing? And did they know that in result of your study? So you looked at it, did they know they were making bone density improvements, or did they not know in your study?
Well, the only way you can report a change in bone mineral density is through a DEXA scan.
Right.
Yeah. That's the only way you can show that change.
They didn't know that their bones were changing.
No, they didn't
There
know.
was no way of knowing.
Right.
Changing. However, there are other changes that occurs in the body.
Right.
They saw the force that they were able to produce got higher and higher and higher.
Lots more force.
Yeah. Yes.
How reliable, excuse me, is DEXA scan in measuring progress or lack of progress?
Oh, how reliable is it? As medical tests go, it's terrible. However, it's the best for both. It's the best thing they have. So the problems with DEXA scans is it stands for dual X-ray absorptiometry. So there's 2 X-ray beams that go through your body, and where they meet determines the density or porosity. But the problem is it's a little like lining up a camera, where the technician has to get exactly at the right part of the bone in your hip. And because you're not, just a skeleton, there's like, a whole person wrapped around your skeletal system, which is you. They can't always determine if they're really x-raying exactly the same spot. So sometimes what's called the bounding box is in a slightly different place, and it doesn't necessarily give the most accurate results. So there's a lot of clinical research that shows that when getting a second DEXA scan to determine what your progress is, you want to go to the same machine and the same technician. Right, because the way it works is a little more of an art than a science, unfortunately. So you gotta have the same person do it because there's slight nuances at times with different individuals. Yes?
I have RAs, plus I have 2 bulging discs in my back.
Okay.
The arthritis started in my feet, and I had bone loss in my heels.
Okay.
So this will help me, wouldn't it?
This can help you. So one thing Basil was trying to say is the individuals that engage to the highest degree get the biggest benefits. Right. So the greater forces you can put through those joints. Now, rheumatoid arthritis, the question was about rheumatoid arthritis and bone loss. Rheumatoid arthritis, that's going to be, this specifically will not do much for that, but it can build up the joint capsule, the tendons and ligaments that surround the joint, and reduce some of the pain that you can feel. There's not necessarily consistent results there because some RA patients can't really engage. Yeah. Right. So as engaged as you can be will be the difference, and that can start a trend going in the other direction. Yeah. Yes.
You've talked about hip and spine. What about other joints like knees, elbows, wrists?
Well, from an so the question was why do we always, when talking about osteoporosis, talk about the hip and spine? Those are the most commonly broken things. Also, hip has a mortality rate associated with it. Somebody who breaks their clavicle is very unhappy, but it's probably not going to end their life. They can get through that a little bit easy. So those are the 2 areas that are the most studied from an osteoporosis standpoint. Now, from an osteoarthritis, tendonitis is, it's a little different. I could give another hour lecture on that. So let's talk afterward. But basically reinforcing the joint, the tendons and ligaments, provided they're all in the right place and you don't have damage that would require surgery, those tendons and ligaments can become more powerful and the pain can be reduced. Okay, one more question. Yes, right there.
Over who had 3 herniated discs and had surgery to fuse his vertebrae. Is there going to be any problem with him doing this, given his doctor's consent? And was it likely to show real benefit for him?
So
He has a lot of pain.
Okay, the question was, you have a coworker, 3 fused vertebrae. Is there any reason that individual could not do this? No, there's no reason. Unless there's some other, now of course he needs to talk to his physician. You need to get advice from your physician because your physician knows everything that's going on with you. I don't know, he may be hypertensive or something like that. But the point is that dysfunction specifically, we've seen individuals, Basil's seen individuals with fused vertebrae and had great results. Yeah. Well, thanks so much. Yeah.